Okay, so welcome to the fourth recording for prenatal risks and assessments. Um, we'll be looking at kind of how to calculate the length of a pregnancy, when due dates are. We'll also talk a little bit about looking at fundal height and Leopold's maneuvers, kind of determining what position a baby is in. And then we'll talk a little bit more about listening to baby's heartbeats and what we expect that to be. And then we'll dive into some testing that has to be done or is offered during pregnancy. So when will it be, quote, time, right? That is what everybody wants to know, especially when they come in for their first visit. Now, there's lots of things available to people on the internet now, so patients are a lot more savvy. They've oftentimes downloaded their own app that calculates when they were pregnant. As long as they knew their last menstrual cycle, and as long as they're on a 28-day cycle, they'll oftentimes be within a day or two of their pregnancy due date that we calculate at the offices. So basically, what do we need to know? We look for their last menstrual period and the start date of that, not the end date, the start date. We look at, at their conception date, we're already counting that baby as about 2 weeks old. So we look at the estimated date of birth, the estimated date of delivery, or the estimated date of confinement. Those are all the same thing. EDB, EDD, EDC. Oftentimes you'll see the EDC. A pregnancy is about 280 days or 40 weeks, 9 calendar months, 10 lunar months. Gotta love that. One of the things we're going to ask is a little bit about history. We're going to ask about how long are their periods. Are they normal 28-day cycles or are they 30-day cycles? That will affect their due date usually. We'll ask about history of intercourse. We'll ask about signs and symptoms. Why did they, think they were pregnant? And then if they've had a pregnancy test at home, what date was that and was it positive? We utilize all those factors as well as ultrasounds to determine due dates. Now we'll calculate a due date, and then ultrasounds are much better during the early parts of a pregnancy in giving us an accurate date, and usually those will align within a couple of days. One way to determine someone's due date, and oftentimes you'll see this in the emergency room or in the labor and delivery unit, are some due date calculating wheels. And this special little wheel, it turns. You can say, okay, what's your due date? That'll help you determine their last menstrual cycle. Or other way around, when was their last menstrual cycle? It'll tell us likelihood of dates of conception, and then give us estimated dates of confinement or estimated dates of delivery. This is a super blurry picture of one. You'll want to pick one up at the unit and take a peek at it. The great thing is it also has estimated fetal weight and some other data that you may want when you are treating someone who's in pregnancy. So we've talked about the wheel. We've talked a little bit about ultrasound as being most accurate when it's within that first few months of pregnancy. There's less discrepancy between sizes of fetuses early on in the pregnancy, and more discrepancy, like if you have someone that comes in at 8 months, it's never had any prenatal care, and we do an ultrasound. That one could be off by a couple of weeks, really, because it really depends on the growth between fetus to fetus is so variable. But one of the things that we will look at closely here would be Nagel's rule, and I apologize, I'm not sure that that's the correct page for this book. It was in my previous book, but Nagel's rule, we need to know their first day of their last menstrual period, right? And then we'll do a process where we subtract 3 months, add 7 days, and add 1 year. And we're going to go on to the next slide here, and I'm going to give you an example of how we calculate that. So utilizing Nagel's rule, when we think about it, Mom says her last period started 12/12 of 17. So you'll see here that I wrote out that date. We're going to subtract 3 months, okay? So that's going to make that September, right? We're going to add 7 days, so that'll be 19. And then we're going to add a year typically, and that will make her due date September 19th, 2018. Now there's going to be some exceptions when we look at someone who has a January last period, right? We won't necessarily be adding an entire year. We're going to add the 9 months, or subtract the 3 months and add the 7 days. That typically will be kind of what you do. But do look in your book at Nagel's rule. There is at least 1 or 2 questions on it. It's usually a fairly simple, direct question. If you guys can set it up like this, the -3 plus 7 plus 1, you're probably going to get that problem correct. One thing to keep in mind is that oftentimes the NCLEX likes to use Nagel's rule as a test question. Another way that we can tell sometimes about how far along a pregnancy is just by a general measurement, and we measure that fundal height. And so what we look at is starting, towards that second trimester there, at 12 weeks at least, we should be able to feel that that fundus is right at the symphysis pubis. But beyond that, and this is when we get into that second trimester, we actually go and we might look at, okay, is it halfway between the symphysis pubis and umbilicus, that we know they're right around 16 weeks or so, unless there's a growth issue with the baby. So for 20-week baby, typically their fundus will be right at or just below the umbilicus, right? And then after that, we can use a measuring tape from the symphysis pubis, and we go all the way up to the top of the fundus. And typically, between 22 and 34 weeks, it'll be within a centimeter or 2 of the gestational age. So if mom is 24 weeks, typically that little tape, then as we look at the top of the fundus, will be right around 23 to 25 centimeters. This gives us a rough view as to whether or not this baby is growing as expected. In fact, one of the things that we'll note is that not everybody gets an ultrasound with every visit to their OB, right? But if an OB doctor takes the measuring tape and measures the fundal height, and it's 2 or 3 centimeters below where it should be, then they're going to pull out the ultrasound. Or if it's larger than it should be, they're going to pull out the ultrasound, because that indicates that there's some sort of issue with fetal growth, or there's an issue with not having enough fluid around the amniotic sac. But it is kind of nice to know that even if you're just looking at someone who's pregnant, sometimes you can tell by looking at them about how far along they are, because if that fundus, if they don't even look pregnant, they're likely under that 12-week mark, right? If they're just starting to look pregnant with a little, I always say they swallowed a taco, that's usually right around that 14 to 16-week mark, because that uterus is starting to climb out of the pelvis. And then it's always nice to know when you're working in an ER, if you look at someone and you can tell that that fundus is right about at the umbilicus, you know that they're 20 weeks, they probably should go up to labor and delivery, right? That's about the right size. And beyond that, even in the ER, even if you don't know when someone's due date is, you can actually do a little measurement, and that will give you a close enough idea to know, should they be going up to OB and labor and delivery for their care, or should they stay in the emergency room? One of the techniques that you'll see in prenatal appointments will be determining the lie of the fetus, and we'll talk a little bit more in depth about this when we get into labor and we're looking at labor positions and what lie is the fetus. The lie is the relationship of the fetus to the vertical axis on mom. And so we use what we call Leopold's maneuvers. And this helps us to determine, is this baby head down? Is it transverse? Is it, could it possibly potentially be a breech baby, that sort of thing. And so how they do this, and it's really good to look up like a video on YouTube about Leopold's maneuvers just to see it in progress. Now, what you may notice is that if you're at the OB office and you're observing, you may notice that providers are doing this without really even explaining what they're doing to the patient. But you'll see them, what they'll do is they'll kind of go at the top of the uterus, and you'll feel them feeling the top of that fundus. And they may be trying to determine, is that a head or is that a bottom end on that baby? Then they will look for the determination of where the back is. So you'll see them go down each side with their hand, and what they're feeling for is there a firm little back there? If there's a firm back, they'll follow it all the way down, and then they will look for engagement. What part is engaged down towards the pelvic bone? Is that a head down there? And then they're going to look at, is this baby rotated funny? So then they'll kind of do some other maneuvers. And you guys are not expected as nursing students to do Leopold's maneuvers. However, you are expected to recognize that we utilize these frequently during appointments just to see what sort of position that baby is in and to identify if there's any risks that we need to maybe do an ultrasound or something like that. So the most common test that you will see in the office will be the fetal heart auscultation. So we know that we use, fetal heart rate to tell us the well-being of the baby in there. If you don't have a fetal heart rate, you don't have a live baby, right? So you will see that parents are very anxious to hear their baby's heart rate and that this creates a lot of emotion because this really makes it real. So we do auscultate fetal heart sounds at each visit. Typically, we look for that fetal heart rate to be between 110 to 160. Knowing that we can sometimes catch mom's heart rate, and that's that uterine artery, we can sometimes hear that pulsing. And so it's really important to make sure you're catching the fetus heart rate and not mom's. The fetoscope is something they use in other places. We don't typically use that in our area unless it's at a nurse midwife's office. Most places, even a nurse midwife's office, will use some sort of Doppler or an electronic fetal monitoring. And then oftentimes we'll do what we call a non-stress test in the office. So typically when a provider auscultates for the fetal heart rate, basically they'll try to go anywhere from 15 seconds to a minute. A lot of them like to get a full minute so that they can count it and determine that it's between the 110 to 160 beats per minute and that it's not slowing down at any point in the middle of it. We typically will use the electronic fetal monitoring when we're trying to look at it for a period of time, and that's the one that we strap onto the belly. We'll use that anytime someone comes into triage because we know that they're at risk. They're there because something is wrong. But you also see it in the offices when maybe someone has a complicating factor or they've had a history of a loss, that sort of thing. We may be watching that baby for a little bit longer time, and we typically will call that a non-stress test. So a non-stress test is when we're not creating any sort of stress for the fetus. In other words, we're not giving that mom contractions, right? And so we'll do a non-stress test prior to any sort of procedure if we're going to do anything with mom reversion or if we're going to take them back for a C-section. Oftentimes, before we even start Pitocin for an induction, we're going to do a non-stress test. This is not uncommon to do in the office just to make sure that even over a period of 20 minutes that this baby looks okay, especially if there's any concerns from the mother's or the provider's side. What we look for in a non-stress test is that in over a 20-minute cycle that baby has several accels or accelerations, meaning the heart rate goes up by 15 beats, lasting for 15 seconds or longer. And we look for that to occur again in that 20-minute window. If not, we might do some things like roll mom to the side or give her a drink of orange juice and see if we can get that baby to react just a little bit. Now we'll talk a lot more in depth about this when we get into labor and we're discussing fetal heart rates and reading strips and that sort of thing, because as nurses we have to analyze whether or not those babies pass the non-stress tests. Whether you're in the office or whether you're at the hospital, you're going to be looking at those strips. So we'll do a lot more with this terminology and learning about these non-stress tests when you get to labor and delivery. Okay, so screenings are a typical process for the obstetric world, right? So we are going to screen moms and their babies for anything that we think could put them at a higher risk for a poor outcome. And so a lot of these are routinely offered. Oftentimes that very first visit, we're going to get an initial ultrasound and check that baby and make sure that the anatomy looks okay to where it's supposed to be. We oftentimes will do a pap smear. Blood work, as far as that goes, we always get a CBC. We're always looking for anemia. We're always looking for platelet counts. We're looking for any sort of infection. We're going to look at HIV. We're going to do usually a urine culture. We usually will draw a rubella titer. Are they rubella immune or not? We will draw their blood type and type that out. We'll do a Hep B and a Hep C screen as well. We'll look for what we call a VDRL. So we'll be checking for syphilis, chlamydia, gonorrhea, And typically we'll screen their urine at every visit. It's not unusual anymore for some providers to also do a drug screen on their initial admission visit to their practice. And although that's not, everywhere, that's certainly becoming a lot more common. Sometimes it's based on history, but in many places it's just a straight across, everybody gets the same testing. So we offer to all women what we call the fetal chromosomal anomalies, where we're looking for Down syndrome, trisomy 18, trisomy 13, Turner syndrome, and these, testing we can usually do during that first trimester uh, via ultrasound. They look at the thickness of the fetal nuchal fold, and it's called a nuchal translucency, or an NT test. And sometimes we don't have ultrasound techs that are able to do the NT test, and in that case, we'll almost always, do just the beta HCG test. And so oftentimes those HCG values will be increased with chromosomal abnormalities, and we kind of look at plasma proteins as well, called the PAP-A. So anytime that we have elevated beta HCG or a low PAP score, suggests that we might have a trisomy of some kind. Then we'll oftentimes want to confirm, because oftentimes these tests will just tell us there's an elevated risk, and we'll want to offer genetic counseling. We'll also want to probably do what we call a chorionic villus sample, or amniocentesis during their second trimester. So if they get these tests and screenings done in first trimester, oftentimes then they'll just do a simple chorionic villus sample, where they actually just take a little piece of the chorion, and then if it's in second trimester, they'll do an ultrasound and do an amniocentesis and draw off some of the amniotic fluid for testing. So almost all women will opt into the quadruple screen. We don't really use the triple screen very much anymore. Most often we just do the quad screen. And we take mom's blood. So it's not even based on baby's blood. And this is absolutely amazing. We do this between week 15 and week 20 of pregnancy. And it detects specific markers in mom's blood. They're called alpha fetoprotein, the HCG, or the human chorionic gonadotropin. And then sometimes we'll look for what we call unconjugated estriol and inhibin A, which is a placenta hormone that shouldn't be in mom's bloodstream in a high amount. And so anytime there's any of these higher than normal, what we call AFPs, then at that point we will know that that baby's at an increased risk for something like a neural tube defect. Maybe there's more than one baby in there. We might also be looking at a baby that's further along than we previously anticipated. And then a lower than normal AFP sometimes indicates that that baby could have Down syndrome, and we'll do a little bit more look, at the trisomy 21 or the trisomy 18. And if we look at HCG and inhibin A, and those are higher, higher HCG and a lower inhibin A, then we also know that that mom's at risk for having a Down syndrome baby. And so fetal DNA actually circulates freely in mom's blood. It's not cellular, but baby's DNA, little chunks of that can be found in mom's blood. And so it's always really interesting that, a long time ago we couldn't draw mom's blood and determine what was wrong with baby, but now we have that ability to test the infant's genetics, even without going into its protected little environment. So, one of the tests that we look at are sometimes amniocentesis, where we're drawing off some of the amniotic fluid, and that carries some risk of that water rupturing, or a baby miscarrying, or getting into the placenta and causing bleeding and detachment, that sort of thing. So, that carries with it the risk of spontaneous abortion. And now that we've found that there's this what we call cell-free DNA that belongs to the baby inside mom's blood cells, it allows us to draw mom's blood and then do some genetic testing, and it is no risk to the baby, which this is a great a development in the abilities of where science has come as far as being able to detect if there's a health condition with the baby. So later on in pregnancy, we actually screen mom for a couple more things. So somewhere between 24 and 28 weeks of gestation, we'll do the gestational diabetes testing that ACOG recommends. And we do what we call a 50-gram glucose challenge test, where we check their glucose, then we have them fast, we have them drink 50 grams of sugar basically, and then at 1 hour we draw a screen from that. And if mom's blood sugar is abnormal, then we will kind of do like a little bit more of an oral glucose challenging test or tolerance test, where we'll give her 100 grams of sugar after fasting, and then we'll give her that, and then we'll wait 3 hours, and she has to basically wait at the hospital in the lab that 3 hours and then have her blood drawn again, because we don't want her to have anything else to eat or drink in that period of time that might elevate her blood sugar. And then we check that glucose tolerance test, and if that indicates that that is sometimes, an issue, then we are pretty sure that we've got gestational diabetes, and we'll start to manage that. You'll find that some places do the 1 hour glucose challenge test, a lot of places do the 2 hour 75 gram, and then if they fail either of those, then we screen them with the 3 hour testing. Oftentimes at that point, we'll also do a hemoglobin hematocrit, but we'll also do that glycolated hemoglobin test, where we're looking back at their average blood sugar over the last 3 months, and that sometimes will also give us an indicator as to if that's a new onset or if they've been struggling with their blood sugars all along. Again, you've got cortisol increases from having the pregnancy going on and hormonal things, and so that does increase the tolerance level, and so a lot of times they're not transporting that insulin as efficiently into the muscle tissue, so not utilizing it as efficiently. Another test that we'll do somewhere around 35 weeks, and I think most offices do it right at 35 weeks, just in case someone goes into preterm labor, is the Group B strep test, and that is we're testing for Group B streptococcus, and we actually swab the perineum, the vagina, the perineum, and the anus, and then send that away for testing. And if that comes back with Group B strep, which is about 1/3 of the population, it's a normal flora that a lot of moms carry, but at delivery can cause baby to inhale that and then create like a pneumonia of an infant. And so we oftentimes will, it's actually become like this whole process of we screen them for GBS, and then they'll go into GBS protocol. So the GBS is just Group B strep. If they are positive, we'll treat them with antibiotics as soon as they come in labor, and we want them to have at least 2 doses, and that will lead then also to the protocol for the infants to not be released home at the 24-hour mark, that they oftentimes have to stay a little bit longer. Okay, so that is the end of part 4 for the prenatal assessment and screenings. That should be it for the chapter.